Good evening, everybody. Welcome to the first Breathe Easy Pulmonary Wellness for All webinar. I welcome you tonight, and we're going to have some fun. And so just to start off a little bit, I would like to explain a little bit about how we operate and about how these Q&As work. So I want to say also that great discussions on the board this week, really interesting questions, really interesting comments. And you know, our group is really, it's really on a roll, and I say that, you know, not just in terms of the numbers, you know, we're growing all the time, but I'm really thrilled with the camaraderie on the board. I'm thrilled with the quality of the questions and the support that people are giving each other. And it's really, you know, obviously you could tell I spent quite a bit of time there, and I do that because I think it's really important because, you know, people are asking good questions that they need answers to. And you know, for me, I mean, people ask me how I have enough time to do it. Believe it or not, I mean, most of the stuff that you're asking me, you know, is not stuff that I have to really research a lot. It's stuff that's pretty available to me. And it, you know, if I could take 30 seconds and help you out, and you know, get you out of a jam, or answer a question that you might have to wait 2 weeks before you see your doctor for, I'm more than happy to do it. So you know, don't feel like you're bothering me or anything like that. By all means, keep the questions coming. That's what I'm here for. That's what this group is here for. So just to start off for 1 minute about the webinar. So number one, I'm not a physician, okay? I'm a physical therapist. I have a doctorate in cardiovascular and pulmonary physical therapy. So that being said, I've been doing this for 23 years. I am the director of the Pulmonary Wellness and Rehabilitation Center. My areas of interest and specialty are cardiovascular disease, pulmonary disease, and complex medical patients. So patients with multiple medical conditions or very complex conditions. And that, you know, will go a lot towards COPD, pulmonary fibrosis, and also pulmonary hypertension, but everything, you know, across and in between. That being said, everything that I talk about is based on my own experience over the past 23 years and is not a substitute for your care with your doctor. So these are my opinions. Don't run out and say, Noah told me to do this. I'm here to present ideas to you, and I'm here to present information to you that you can then share with your doctor. But please, everybody is different. I don't know you. I haven't examined you. So what I'm speaking about is general things that work with most people, but any lifestyle change, it's really important that you clear with your physician to make sure it's going to be safe. So I think Chris just explained to you how to ask questions. And what I'm going to do is, do we have questions yet on the board? Where would I?
Not yet.
Okay, so I'm going to start with some questions that I've gotten already. And please understand that you know, if you send me a very specific question about yourself, that is going to be a less likely question that I get to, because what I'm going to try to do is I'm going to try to take questions that can apply. Now, people can ask me specific questions, and I'm going to try to take that information and apply it to the most number of people possible. So if you ask me a question about exercise or about nutrition or about something like that, I'm always going to try to take it from the perspective of obstructive disease, okay? And tonight, because it's the first one, I'm going to be setting out a lot of guidelines. So I'm going to talk about broad strokes. I'm going to talk about general principles that will come up over and over and over again throughout my teaching, okay? So I'm going to apply these things basically to obstructive diseases, and I'm going to apply them to restrictive diseases, and I'm also going to apply them to cardiovascular diseases. And that's the first thing I'll start by talking about. So when we talk about respiratory disease, okay, basically respiratory diseases are going to break down into two broad categories, and that's going to be obstructive diseases, and that's going to be restrictive diseases. So Breathe Easy used to be COPD Breathe Easy, you know, and it was very COPD slanted. And I want to, you know, part of the reason why I want to make this Pulmonary Wellness for All is because the way that we treat obstructive disease and restrictive disease, particularly as it comes from a rehab and lifestyle perspective, and also part of the way that we treat a lot of cardiovascular diseases, such as pulmonary hypertension, is often the same, okay? And a lot of times people try to get involved in a conversation and they'll say something like, oh, that doesn't apply to me because I have IPF. You're talking about COPD, and they say this a lot related to pursed lip breathing or pace breathing, and so on and so forth. Or they'll say, well, you know, I have COPD, and that has nothing to do because that's about restrictive disease. And that's not really true. So, but before you think like that, just understand that I know who you are, from the perspective of your disease type, and I know how to treat you. So when there are similarities, okay, I'm going to tell you that the treatments are similar. When there are differences, I'm going to say, so for people with obstructive disease, you might need this, whereas people with restrictive disease might need this, and people with pulmonary hypertension might need this. But just understand that in the same gym, okay, in my gym that goes on every single day, we're seeing people with COPD right next to people with asthma, right next to people with IPF, right next to people with interstitial lung disease, right next to people with cystic fibrosis, with sarcoidosis, with pulmonary hypertension. And I can assure you, I know the treatments are similar, if not the same. And like I said, where they're different, I'm going to tell you the differences. So again, broad stroke, obstructive versus restrictive disease. So when we talk about obstructive diseases, what we're talking about are diseases where you have a problem with exhalation, okay? So inhaling is no problem, but when you try to exhale, particularly when you try to exhale forcefully, there is a narrowing of the airways due to inflammation, okay? So we are talking about narrowing of the bronchi, which are the airways, and also collapse of the alveoli, and the alveoli are the air sacs where gas exchange occurs. So think of it like this, almost like a roach motel, and I hate to tell you to think of your lungs like a roach motel, but air gets in, but it doesn't get out, okay? And so the net effect of that is that you have difficulty with exhalation, and you wind up trapping air, and so as a result, you wind up with actually a larger lung, okay, and what we call hyperinflated lung, and that's where this idea of a barrel chest comes in, right, because there's so much lung volume in there, and the lung doesn't really empty, okay? So that is obstructive disease, but keep in mind that this is really like a yin and a yang situation. What goes up must go down, what goes in must come out. And what I mean by that is that if you have trouble with exhalation, you're also going to have trouble with inhalation, okay? So that's obstructive disease. When we talk about restrictive disease, okay, we're talking about difficulty inflating the lungs, or difficulty with inspiration, okay? And what that means is that that person has a hard time filling their lungs, and as a result, the person with restrictive disease is going to wind up with a smaller lung, and also usually a smaller chest cavity and a smaller chest wall, okay? So in either case, what's important to understand is that the amount of air that you're actually moving in and out with each breath is diminished in both cases. However, in obstructive disease, the small amount of air is moving at a larger lung volume, right? So the lung is full, the amount of air moving in and out with each breath is still small, but it's happening all the way out here. In restrictive disease, the amount of air that's moving in and out with each breath is also small, except that's happening at a lower lung volume, okay? So that's principle number one, obstructive disease versus restrictive disease. And obstructive disease is, again, difficulty with exhalation. Restrictive disease, difficulty with inhalation. And if you want to talk about which is which, how do I know which I have? The obstructive diseases are COPD, okay, and here comes another important thing that I talk about all the time. COPD is two diseases, okay, and COPD refers to chronic bronchitis, which is disease of the large airways in the bronchi, and emphysema, which is disease of the small airways and the alveoli, which, as I said before, are the air sacs, okay? So people talk all the time about, well, COPD is an umbrella term that includes many diseases, including emphysema, chronic bronchitis, asthma, bronchiectasis, and they go on to name all these different diseases. No, it's not, okay? And listen to what I'm about to say, and I don't care who on the internet is telling you differently. When we talk about COPD, we're only talking about two diseases, emphysema and chronic bronchitis. So what does that mean? If you have emphysema, you have COPD. If you have chronic bronchitis, you have COPD. Either or. So if you have emphysema but you don't have chronic bronchitis, you still have COPD. If you have chronic bronchitis but you don't have emphysema, you still have COPD. Okay? Now you can have COPD and not have chronic bronchitis if you only have emphysema. And you can have COPD and only have emphysema and not have emphysema if you only have chronic bronchitis. So now let's talk about asthma, because people always want to throw asthma into the mix, and now unfortunately the tail is wagging the dog, And I've seen several articles lately saying that doctors are going to start including asthma under the COPD diagnosis. And I'm going to tell you this, not if they're smart. And I'm going to tell you something else. I don't even think it's going to happen. I think this is some blogger or somebody who caught on to this confusion. And when people are confused, they speak in vague terms, okay? If you understand specifics, you know that you can explain things specifically. When people start saying things like, it's an umbrella term that's sort of like, and then they fade off as they keep talking, don't listen to them, okay? And there's a real reason why asthma is not and should not be included under COPD. Let me explain the reason why, okay? When you have a pulmonary function test, remember, you are asked to take a deep breath in and blow all the air out slowly, right? And this is called a SVC, slow vital capacity. And the reason why this is asked to be done is because in general, when you have an obstructive pulmonary disease, the harder and faster you blow out, the more airway narrowing and the more air trapping you get, meaning that the more obstructed you become, okay? So when you take the slow vital capacity, you take that deep breath in and that long breath out nice and slow, we're trying to find out, okay, how much air is coming out from maximal inhalation to maximal exhalation. Now, this is a PFT lesson, so pay attention, okay? Next thing they ask you to do is they ask you to take a deep breath in and blow out as hard and fast as you can. This is called forced vital capacity, okay? So we had slow vital capacity, SVC, or sometimes it's just listed as VC. And the other thing that we have now is called forced vital capacity, or FVC. And that's one of the most important numbers of your PFT. So what we do is the deepest breath in, blow out as hard and as fast as you can. And the reason why this is compared to the slow vital capacity is because when you blow out hard and fast, that elicits the obstruction for diagnostic purposes, okay? So then the other number that we have is the FEV1, and that's an important number also, and that's the forced expiratory volume in 1 second. And the significance of the forced expiratory volume in 1 second is that 80% of the air of the forced vital capacity should come out in the first second of blowing out. So remember, we have that amount from maximal inhalation to maximal exhalation, and 80% of that should come out in the first second. So if you have obstructive airway disease, that means less than 80% is going to come out in the first second due to increased air trapping and airway narrowing, okay? And then the last thing that's important is FEV1 over FVC is the ratio of the first second over that, and that's what should be 80%. So that's obstructive disease, okay? And the thing is that after you do that, okay, you're asked to take a bronchodilator. So you're either given a puff of your pump, the MDI, albuterol, or Xopenex, or something like that, or you're given a nebulizer and you're retested, okay? Now, essentially what's going to happen is for people who respond well to that, in other words, if we see a significant difference between pre-bronchodilator FEV1 and FVC versus post-bronchodilator FEV1 over FVC, we are going to call that reversible airway disease, okay? If there's no change, we're going to call that fixed airway disease or irreversible airway disease. And basically, reversible airway disease refers to more of an asthmatic diagnosis as compared to irreversible airway disease, which refers more to a COPD diagnosis, okay? And the thing is that the reason why this is important and the reason why they should never be treated together is because the way that asthma is diagnosed and treated is different than the way COPD is. Emphysema and chronic bronchitis have similar presentations, similar treatments, and that is why that's COPD. So this is all obstructive pulmonary diseases. Other obstructive pulmonary diseases include bronchiectasis, and again, COPD is emphysema and chronic bronchitis, and here's where it gets confusing. Asthma is ACOPD, okay? And what I mean by that is it is confusing, okay? It is a chronic disease. It is an obstructive disease. It is a pulmonary disease, meaning it's the lungs. And it is a disease, okay? So asthma is ACOPD, but it does not fall under when we say COPD, okay? Bronchiectasis is a COPD, but if it's not emphysema or chronic bronchitis, it's not COPD. Cystic fibrosis is a COPD, but again, if it's not emphysema or chronic bronchitis, it's not COPD. Now, restrictive disease, okay, is different, okay? When we talk about restrictive disease, generally what we're talking about is interstitial lung disease, and interstitial lung disease includes things like idiopathic pulmonary fibrosis, IPF, non-specific, pneumonias, pneumonitis, pneumoconiosis, and a lot of the occupational exposures. But in general, that's the difference between obstructive disease and restrictive disease. Okay, so I hope that clears things up. The other thing I want to tell you right now, and you'll know this from the Breathe Easy group, is that very often I will post links to previous webinars, okay? So right now we have about 25 different webinars posted on the website, www.pulmonarywellness.com, under the web archive. So if you start at number 1 and you work up to 24, you're ready to start practicing medicine at a very high level, okay? Because I have everything in there, and some of them are repetitive, and a lot of what I say is going to be repetitive because I'm trying to teach you and get you to understand, and a lot of times it helps to weave things in and out in the context that I know that you're going to get them. So now let me go to a couple of questions, okay? And here is a question from one of my biggest fans, Barbara, okay? And Barbara, I've seen defending me all over the internet when people call me names and, post negative photographs of me in compromising positions. But Barbara B, thank you, and hello from Monquito. So here's a question. To work on overcoming my usual winter downturn, last Thursday I started my second stint of pulmonary rehab. I started my second stint at pulmonary rehab. So the winter downturn, okay? So a lot of us have been indoors this winter. It's been a tough winter, okay? So naturally, we're gonna be more short of breath. We're gonna be less conditioned. Now is the time to get moving. I actually tell people to get moving and rehabbing during the winter because we know the winter is gonna be downtime. That's the perfect time to make sure you're getting your exercise. So that when it actually becomes springtime, like now, you're ready to get out there, enjoy it, as opposed to sort of doing nothing, hibernating all winter, and now it's time to actually get moving again. You can enjoy it, but you're going to be out of shape from the long winter, and you're going to be more short of breath. Now, have no fear. It doesn't mean, just because you're more short of breath right now, does not mean that your lung function has gotten worse. It's very possible that you've just become deconditioned. So another topic that I talk about all the time is the fact that breathing is multifactorial, okay? Meaning that there's a lot of factors that go into breathing besides just lung function and the respiratory system. Some of these things include level of conditioning. So are you fit? Some of these things include, are you over or underweight? So if you've gained 30 pounds this weekend, not this weekend, if you gained 30 pounds this weekend, then you have been partying hard. But if you've gained 30 pounds this winter, okay, imagine 15 pounds strapped around each one of your ribs, and every time you need to take that deep breath, you have to increase the work by 15 pounds each side, by 30 pounds in order to take the deep breath. So again, don't be discouraged by the fact that you're more short of breath. Don't be discouraged by anything, okay? Everything that I try to tell you is this, okay? We are where we are right this second, for better or for worse, okay? And now is the best time to start implementing change. Don't beat yourself up and say, oh, I shouldn't have smoked those cigarettes. Oh, I should have done more exercise. Oh, I shouldn't have eaten that Big Mac. Oh, I shouldn't have blah, 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 so on and so forth. We are human. We make mistakes. We do things we shouldn't do. It's part of being human. It's part of the fun of being human, is doing the things that we shouldn't do. But sometimes there are consequences, okay? But that being said, and I hate, this is a phrase I don't really like, but I'm gonna say it because it makes sense. Today is the first day of the rest of your life, okay? Here's how I like to say it. The best time to plant a tree was 25 years ago. The second best time is today. So let's get planting, let's start making these implications. So here's Barbara's question. While exercising, what are the benefits of drinking water besides quenching thirst? Okay, so let's talk about this. So obviously it's quenching thirst. Obviously it's wetting your mouth, okay? So when we're exercising, part of what we're trying to get you to do is we're trying to get you to take deep breaths in through your nose, out through your mouth. But it doesn't even matter if you breathe in through your nose or out through your mouth, because we know that air can enter in two spots. So when air enters through your nose, it goes up your nasal passage, it goes through what we call the nasopharynx, and then it goes to the back of the throat where it's called just the pharynx. When air enters the mouth, it goes in through your mouth, it goes in through what we call the oropharynx. So if it goes through the nose, it goes through the nasopharynx. If it goes through the mouth, it goes through the oropharynx. The nasopharynx and oropharynx meet in the back in the pharynx. So essentially, whether you take air in through your nose or your mouth, you're going to be moving air in and out. So if you think about a wet floor, okay, and air is blowing over it, obviously the floor is going to dry out more quickly. And if you add to that mix oxygen, okay, which is very drying on its own, it's going to dry out even more. And I know that a lot of the oxygen concentrators in particular come with a bubbler humidifier, and they do make a difference, but they don't make a giant difference, especially if you're using high liter flow. So if you're using 4 to 6 liters of oxygen, that's going to be pretty drying. So you do have to replace that, okay? But more importantly, the body is made up mostly of water, okay? And water is essential to every single bodily function known to man. So if you're dehydrated, everything is going to be affected by that. And that has to do with a lot of different things. Besides just being, the solution that everything is dissolved in, the solution that blood is made up of, things of that nature, it also has a lot to do with concentration of the various elements of our blood. And particularly when it comes to exercise, it has a lot to do with electrolytes. So when we talk about electrolytes, we're talking about things like sodium, potassium, chloride, let's see, what else? Others as well, okay? And if you think about it, the body likes a certain combination, or a certain concentration, I should say, of these various electrolytes. So like in the same way that if you had a cup of water and we were going to make iced tea with it, okay? There's gonna be a certain level, and I know for the Southerners in the room, what I'm about to say is going to be very disturbing to you, okay? But I'm talking about powdered iced tea, okay? I'm sorry to say, okay? But let's say we're using powdered iced tea. There's gonna be a certain amount of iced tea where we are gonna start to add iced tea, and it's gonna get better and better, and we're gonna keep tasting it, and we need a little more iced tea, and it's gonna get better and better, and there's gonna come a point where that iced tea is perfectly delicious, okay? That's what we call homeostasis in the body. The body likes homeostasis. It likes it to be perfectly the same, and the body is always gonna be adjusting fluid balance by making you pee and making you more thirsty in order to maintain that perfect iced tea, albeit powdered, okay? Now, if you have that perfect level of iced tea, and then you add a little bit more iced tea, well, now we've gone over the edge, and now that's too much, okay? So think of the iced tea as sodium, or chloride, or potassium, okay? And so the point is, if we don't have enough, so in other words, if we don't have enough tea in here, the body will try to rid this tea of all the excess water until the concentration is perfect. And if we have too much in here, the body is going to try to bring in more water and retain more water in order to slow that, in order to water that down, okay? So what does that mean? Okay, if we think about it from a sodium perspective, because sodium is really important, and we're talking about salt, and this is really important because you can actually affect this by what you eat. So let's say, for argument's sake, I go to Katz's Deli on Houston Street in New York City, and I order a pastrami sandwich, and I put extra salt on my sandwich, and that's like putting a whole bunch of iced tea into this cup of water. And the cup of water is the volume of our body fluid, okay? Think about it. That's like the sweetest, most disgusting, humanly possible iced tea possible. And as a result, the body is gonna say, you know what, this is disgusting. We have to get more fluid in, and no matter what, we're not letting more fluid out, okay? So think about that. Until you can process that sodium, the body's gonna bring on more fluid, more fluid, more fluid, more fluid, And what happens when your body brings on more fluid because you are drinking so much, eating so much salt, is that increases the workload on the left ventricle, okay? If you have any type of heart problem, the left ventricle is going to have trouble meeting the demand of pumping, and that blood can back up into the left atrium, and if it continues to be a problem, it could back up into the lungs, okay? And this is what we're referring to when we talk about left-sided heart failure, and that will then go back to the body, and that leads to pedal edema or edema in the feet, okay? Another way to know you've taken on too much salt is you can weigh yourself, and maybe you've gained 2 or 3 pounds overnight, sometimes more, depending upon what you eat. So that's why fluid balance is very important. And when you think about supply and demand, the greater the demand, the more fluid you're going to burn off. So Barbara, and everybody else, it's not so much, don't think of it in terms of it's absolutely crucial that I drink during the workout, okay? That is not the most important thing. What's the most important thing is that you think about fluid volume and making sure that you're well hydrated over a 24-hour period and over time. So let's just hit this with and then just one thing before I talk about how much water you should drink. The second part of that question is, can you explain how the loss of body fluid during exercise affects your blood pressure? So again, don't think about it during the course of exercise, because quite frankly, the overwhelming majority of us, okay, or the overwhelming majority of people that come to pulmonary rehab, you're not sweating so vigorously that you're losing enough fluid volume to really affect your blood pressure, okay? It's not that. For the average person who comes to pulmonary rehab, your blood pressure is going to be more affected by the lack of drinking enough. But let me explain how that works. So we have a certain amount of total fluid in the body, and we will call that total plasma volume. So if we think about the amount of fluid in our body as being a water balloon, right? So let's say the water balloon has a certain amount of water in it, and we take the blood pressure. So let's say that water balloon has enough fluid in it to make your blood pressure 120/80 while you're sitting and doing nothing, which is normal blood pressure, okay? Now, let's say we increase the amount of water in that balloon by 25%, okay? So we haven't increased the space. We've just increased how much fluid in it. So you could see how that is going to increase the pressure inside the balloon. And it's the same thing when I talk about this. So if you have that big salty meal and all of a sudden you put on 5 extra pounds of fluid, that's going to increase the fluid. And for the most part, the body is able to adapt to this by decreasing the pressure in the blood vessels, by dilating the blood vessels and decreasing the pressure. But when you throw into it things like heart disease, vascular disease, pulmonary disease a little bit, and then some of the medications involved, it's going to increase the pressure. Now, likewise, if you're dehydrated, okay, imagine that we have this body of fluid inside a water balloon, and now we let out 50% of the fluid, right? So you can see how letting out that fluid without replacing it is going to decrease the total plasma volume, thereby decreasing the blood pressure. So I hope that answers that question. Chris, do we have questions?
We have 2 questions.
Where are they? Okay, we have 5 questions, I see.
2 only.
Okay. All right. I'm going to go to one of the questions from the audience. Can you pull that up for me?
Sure.
Can you get it from there or here?
Oh, you take care of the question.
Okay. So let me get you another question from the audience that was sent to me. Okay. So I recently read an article by UNC Pulmonary that stated testing was done and it was found that in COPD patients versus asthma patients, corticosteroids are not necessary. A new drug is a once-a-day combination drug of long-acting anticholinergic and beta-2 agonists, and that new drug is called Ellipta. Okay? For so many COPD patients, it seems like a corticosteroid is required, and we have been taking them for years. I have been on either Advair or Symbicort for 10 plus years with the side effects of terrible bruising and leg cramps. You have given the procedure to take your Spiriva and then wait 15 minutes for Symbicort. What do you think about the new Anoro? Okay. So let's address this. When we talk about the different types of medications, okay? First, we should talk about the various routes of medication, okay? So, in general, you can take medication orally, you could take medication IV, you could take medication topically, meaning you rub it on, you could take medication rectally, or you could take medication inhaled, as in the inhalers that we take, okay? IV, oral, meaning swallowed in pill form, rectal, these types of delivery are going to have what we call systemic effects, okay? Because they are basically going to get into the bloodstream and circulate through the body in order to have their effect. So when you take something that has systemic effects, it's much less specific, meaning that let's say we take oral steroids like prednisone, or we take IV steroids like Medrol or Solumedrol, okay? This doesn't just affect the lungs, even though you're taking it for the lungs, but the reason why it's so effective is because it goes right into the bloodstream and works very, very fast. So if you go into the ER in the middle of the night, unable to breathe, they're going to give you something IV because, boom, it's almost instantaneous. Now, the problem with taking an IV or oral steroid is that you have these systemic effects. And what are the systemic effects? The systemic effects are increases in your blood sugar. The systemic effects are weight gain due to water weight and fat deposits. The systemic effects are osteoporosis over the long term. And so that is something that people obviously want to avoid at all costs. When we talk about inhaled corticosteroids, okay, we're talking about steroids that you breathe in, and they basically work very effectively because they go directly to the area that we want them, which is the the lungs and the respiratory system, without having to go through the entire bloodstream. And the beauty of that is that you don't wind up with these same systemic side effects, okay? So you're not going to wind up with the same high blood sugars. You're not going to wind up with the same osteoporosis risk. You're not going to wind up with the same weight gain, okay? So keep that in mind. If you go, when we talk about inhaled medication for pulmonary disease, okay? I've broken it down, and for years, I don't know how this is so crazy, I've been trying to think of the way to make it easy for people for years, and it just hit me like 6 months ago how to do it. There's 3 classes of medication, and it's important that you know what you're taking and why, okay? Essentially, there's 2 main divisions of types of medication, and there's 3 classes. The 2 types of medication are what we call bronchodilator, and the bronchodilator means it dilates the bronchi, okay? It opens up the airways. And under bronchodilators, there are 2 different types. The different types are anticholinergic, and the other type of bronchodilator is called beta-2 agonist, okay? And here's where it gets crazy that I couldn't think of this for 20 years, but we have A, anticholinergic, we have B, beta-2 agonist, and then the third class of drugs, which is also the second division of drugs, is C, corticosteroids, okay? So like Michael Jackson says, it's easy as ABC, okay? Anticholinergic, beta-2 agonist, corticosteroid. And traditionally, the treatment for lung disease has been 1 anticholinergic, 1 beta-2 agonist. So we're hitting it from 2 bronchodilator pathways, and then C, corticosteroid, which is anti-inflammatory. Now, it's not always used the same in the restrictive disease. So if you have IPF, okay, you may not be prescribed these different bronchodilators. You may be prescribed corticosteroids. But here's something else that's important and interesting to think about, which is that, basically, there are people who, when we do the pulmonary function test, do not show responsiveness to the bronchodilators, meaning that we don't see an effect, we don't see a reversibility, okay? But clinically, people do feel better. So the question then becomes, okay, well, even though we don't see it on pulmonary function test, should that person be taking a bronchodilator? And the answer is maybe, and that's something you can discuss with your doctor, because who cares if you see the number difference, if you can actually walk uphill a little bit easier. So again, that's something that you should ask your doctor about. Now, as a point of reference, okay, this is a chart that I have in our files, okay? And I'm gonna post it tonight again, and I'm gonna put it in the pinned post tonight, because this is a very good reference chart, and I've broken it up into ABCs, okay? And in this one, for some reason it says BAC. I think this is an old copy that I printed out. But actually I think it makes sense to put it this way anyway because of the way the different combination drugs are. But I will post this tonight. So what you should do at the bare minimum, if you're taking inhalers, is look through these different drugs and figure out what classes are you taking. So look at what you're taking, figure out what you're taking from A, what you're taking from B, what you're taking from C. And you know, it's kind of like the old combination plate in the Chinese restaurant from the 1980s, where you take one from column A, and Chris, the tech guy, is applauding right now because he's Chinese and he's biased towards the combination plate. But basically, it's like one from column A, one from column B, one from column C, and we know that this works best. So the question is, are corticosteroids necessary? Okay, and the answer is maybe yes, maybe no. So if we talk about a neuroellipta is a combination of two drugs. Okay, it's a combination of something called vilanterol, which is a long-acting beta-2 agonist, and umeclidinium, okay, which is a long-acting anticholinergic. So the benefit of that is that you're getting 2 levels of long-acting bronchodilator in combination, and we know that the combination of both works better than either one alone. So the question becomes this, okay, for some people, okay, that level of bronchodilation is enough to offset their shortness of breath over the course of the day. And if that's you, you're only going to know this by trial and error and by talking with your doctor, okay? So if you're one of those people who, guess what, you take that drug in the morning and you get relief all day because you've taken 2 long-acting bronchodilators, then the answer is maybe no, you don't need a steroid. But if you're somebody who's got significantly more airway inflammation, okay, in other words, the inside of your airways, so the inside of your airways are made up of smooth muscle, and that smooth muscle can become inflamed, and when it becomes inflamed, it gets thicker and it narrows out the airway. So if that's your situation, then simply bronchodilating you may not be enough to offer you relief. However, if you add the steroid to that, that will actually shrink the swollen airways, and that is going to give you the relief. And then when you take the Anoro, it's actually going to bronchodilate you further. But again, that's a definite maybe there, okay? And that's something that you really have to discuss with your doctor because everybody is different. Okay, so that answers that question. Here, going to another question. Now, one more thing, and this is related to this as well. So this is from Karen, and the question is, I'm so worried about the side effects from meds, especially on the eyes and bones, not to mention foot spasms and cramps. I have stage 4 COPD, emphysema, pulmonary hypertension. I really like Symbicort, and Spiriva helps too. I have moderately severe osteopenia. For those of you that don't know, osteopenia is thinning of the bones, but it's not as severe as osteoporosis, okay? I don't know the exact percentages. I can look it up. You can look it up. The difference in bone loss between osteopenia and osteoporosis. I have a predisposition to glaucoma due to narrow angles. I'm losing weight due to emphysema and colon resection. Would I be better off with a Noro? And the answer again boils down to what I just said, okay? It depends. So if airway inflammation is a significant problem, then you may need to take something like a Symbicort and Spiriva. So both, if you're wondering why I'm drinking 2 cups of water, it's not because one is vodka and one is gin. It's because this is warm, too warm, and this is cold. Just for the record, I haven't had any drinks today. So the point is, Karen, this, okay? When you take Advair or Symbicort, both Advair and Symbicort are a combination of a beta-2 agonist and a corticosteroid, okay? So with that, you would add Spiriva, and with that, you get all 3 ABC, anticholinergic, beta-2 agonist, corticosteroid. So the question becomes, if that Anoro ellipta, which gives you 2 of the 3 classes, it gives you both bronchodilators but not the steroid, is effective for you, then maybe you don't need the steroid. If airway inflammation is a big problem for you, then you might need the steroid. But the good news, as I alluded to before, is the fact that the inhaled corticosteroids, okay, do not have the same systemic effects as taking oral steroids like prednisone. So with the inhaled corticosteroids, you don't have the same risk for osteoporosis. You don't have the same risk for the blood sugar changes. You don't have the same risk of weight gain. You don't have the same risk of glaucoma. Although I did recently see an article where they were talking about the fact that there was some leakage from, basically in the head and the face, which actually does leave you with some of the more risks for the eye disease. But I've only seen that written about once. It's an interesting theory. I can't say for sure if I think it's true or not. I don't think science knows yet, but I think that if it were as significant a risk as with the oral or the IV steroids, I think we would hear a lot more about it, and I think we'd see a lot more people with these types of complications. I want to just say now it's 7:45, okay? So we're going to go over a little bit. We're probably going to go over by about 15 minutes, okay? Because I want to make sure that I get to all the questions tonight. So hang in there if you can. Let's go to the next question. The next question is from Paula. Hey Paula, and thumbs up on earlier this week, so I'm glad we're good again. So here's the question. Is there a way to breathe easier and get less tired when going up and down the stairs? I get out of breath and feel so tired just going up and down a few steps. And the answer is yes, okay? So when you think about any exercise, and depending upon who you are, okay, that exercise may be walking across the room to answer the phone. For some people, it may be walking up 5 flights of stairs. For the Ironmen in the group, it may be sprinting 100 yards, okay? All of this relates to supply and demand. Okay, so anytime you increase your activity, you are increasing the demand for oxygen. And when you increase the demand for oxygen, that's going to affect 3 major systems, okay? And the thing is that how your body uses oxygen is based on 3 main factors. Number 1, how good are your lungs at moving air in and out? How good is your heart at pumping blood? How good are your peripheral muscles at using oxygen, okay? So any insult or any damage or any deficit in any of these areas is going to decrease the amount of oxygen that your body is able to use and decrease the efficiency that your body uses that oxygen. Now that being said, okay, it's not always that. It's not always oxygen saturation that makes us short of breath. And what do I mean by that? I mean, you could walk up 2 flights of stairs, you could be extremely short of breath, and I could check your oxygen saturation and you could be 96%. And you say, well, I don't understand this. If my oxygen saturation is 96%, why am I short of breath? Good question. But again, that could have to do with lung mechanics. So we know that with COPD, with interstitial lung disease, with restrictive diseases, with asthma, we know that there's an impairment to lung mechanics, and that's how you move air in and out. Maybe it's that, okay? That would fall under the classification of lung function. But it could just be that you're out of shape. So in other words, even if you have no lung disease at all, okay? If you spent all winter sitting on the couch watching Game of Thrones, nothing against Game of Thrones, I love Game of Thrones, okay? Insert your own TV show there. If you sat on the couch watching TV, eating Ben & Jerry's, nothing against Ben & Jerry's, I love my Ben & Jerry's, okay? But you've put on 50 pounds. Again, even without heart disease, even without lung disease, okay? Guess what? When you go to walk up those stairs for the first time, you're gonna be more short of breath. Why? Because you're out of shape. You now have that extra weight pulling down every time you have to take a deep breath, and so on and so forth. So over the long term, the way that you're gonna get less short of breath is by getting in shape, okay? But let's talk about the immediate supply and demand, because what happens a lot of times is people will start to go up the stairs and they are not even thinking about their breathing. They're thinking about getting up those stairs. And you know, in New York City, we got these subway stairs that are not built for comfort. They are built for space saving. So they're long, they're high, and they're steep. Add to that 500 type A personalities that are running to get to work. And people are holding their breath, grinding to get up the stairs. And then they finally get to the top of the stairs and they're going, I forgot which action hero said this, but there's a guy that says your body is right. It's something like your Chris, your something is writing checks that your body can't cash. Do you know what I'm talking about?
I'll find out.
I don't know. We're gonna Google this, but anyway, the point is that stair climbing significantly increases the demand. of not just oxygen, we'll say air, okay? And the point is, if you hold your breath that whole time that you're going up there, well, your demand, that's like you just wrote a check and bounced your check, because you are asking to buy the trip up the stairs. You don't have enough air money in the bank to pay for it, so you just bounced your check. So what do? We need to increase the supply somehow. And how do we increase the supply? We increase the supply by recognizing that we are about to increase the demand, right? So we know we're about to get dinner, we're about to go out to dinner, we better put some money in our wallet, and we do that by starting the breathing exercises before we even get to the stairway. So we have the quote, what is it?
It's Top Gun?
Top Gun, and what is it?
Your ego is writing checks your body can't cash.
Your ego is writing checks that your body can't cash, okay? So don't let your ego, who says it in it?
Stinger.
Stinger. Okay, so Stinger says, he probably says it to Tom Cruise. Okay, so here's the thing. Don't let your ego write checks that your body can't cash. And the way that we make sure our ego doesn't write checks our body can't cash, start the breathing exercises before you get up the stairs. As you start walking up the stairs, continue the breathing exercises. So if you think of each step with your foot, imagine we want to breathe as one count. We want to breathe in for a count of 2 and out for a count of 4. And it's not going to be perfect, okay? It doesn't matter. But at least we're thinking about it. At least we're putting gas in the tank. So breathe in, blow, 2, 3, 4. So and as we do this, okay, over time what winds up happening is the more we do, our bodies get stronger, our lungs get better at moving air in and out, our heart gets better at pumping blood, our muscles become more efficient at using oxygen, and we get better at what we call aerobic metabolism, and we increase our aerobic capacity. Now, I'm going to recommend, if you want to talk specifically about breathing techniques, okay, I'm going to recommend a webinar for you to watch, and I'm trying to think of the guy's name that did this webinar. Hold on one second. Okay, so his name is Noah Greenspan, okay, and the webinar is on www.pulmonarywellness.com, and it's webinar 3, and it's called Dr. Noah Greenspan, Breathe Deep, Your Absolute Breathing Techniques Ever. And that will go through all of the different breathing techniques with you. It will teach you how to use them during activity. And the other thing that it's going to do is it's going to teach you about how to recover from shortness of breath. So what to actually do when you get in a jam. So those times when you're walking and you've overdone it, your ego has written a check that your body can't cash, as Stinger says in Top Gun, and now you're in a jam. And that's the time when you need to say, stop, I know what to do here, and go into the recovery position. So again, webinar 3, your absolute best breathing techniques ever. And I will also post a link to that tonight on Breathe Easy as a, can you just make a note of what we have to post tonight? So we're gonna post the ABC medication list. We're gonna post the easy, better breathing techniques. So that is that, and I hope that helps. Next question from Sharon. Okay. Noah, I have not really done a lot with my COPD because I have significant thickening from cardiomyopathy. What do I think? And I wrote, I think in that case, it's even more important to do a lot. I will discuss this on Wednesday night. And lo and behold, it's Wednesday night. So let's talk about it, okay? So I just told you that there are 3 main factors involved in how your body uses oxygen. And those factors are how your lungs move air in and out, how your heart pumps blood, and how efficiently your muscles use oxygen, okay? So if we think about the body as a car, okay, if the car doesn't have a good motor, if the oil filters are dirty, if the spark plugs are old, if you have the wrong amount of air in your tires, okay, every single one of these things is going to contribute to making the car less efficient. Same thing with your body. So if you have lung disease, your body is going to be less efficient than if you didn't have lung disease. If you have lung disease and heart disease, well, that's going to be even less efficient than if you had either one alone or none of them. If you have lung disease and heart disease and your muscles are poorly toned because you don't do any exercise, well, now that's the least efficient, okay? So the point is, it doesn't, now don't misunderstand what I'm about to say. I'm going to say it doesn't matter that you have cardiomyopathy. Of course it matters, okay? But if we know that you have a problem with your lungs, it's even more important to strengthen the heart. If we know that you have a problem with your heart, it's even more important to strengthen the muscles in the lungs, but it's got to be done right, okay? Because of the cardiomyopathy, and for those of you that have heard this term but don't know what it means, as opposed to coronary artery disease that comes from risk factors like smoking or obesity or high-fat meals, blah, 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 cardiomyopathy is what is known as primary muscle disease. So essentially, there's no known reason for it. It's just that the heart develops disease in the absence of other risk factors. And there are different types of cardiomyopathy. So there's something called restrictive cardiomyopathy, where the heart is very small and tight. There's something called hypertrophic cardiomyopathy, where the heart is very thick and hyperdynamic, but that leads to a situation where it doesn't get enough blood supply. There's something called dilated cardiomyopathy, where you have a big floppy heart that doesn't contract well. So basically what it means is cardiomyopathy. So Sharon, in this case, there are some really important things that have to get done for you to start paying attention to both your heart and your lungs. And the good news about all this is that all the things that are going to help your lungs are also going to help your heart. All the things that are going to help your heart are also going to help your muscles. So if you start exercising regularly, if you start eating better, if you start meditating and practicing some type of stress management relaxation techniques, all of these systems are going to benefit. And when all of these systems are benefit, that's like you just went into shop and we changed the oil filter, we put in new spark plugs, we got a new motor, we put air in the tires, and I don't think I said this before, but we also happened to put some extra fluid in the windshield. Okay, so we're now improving the efficiency of all three systems, and when you work on improving all three systems, they don't just become additive, they multiply. And believe me, I've seen people who are so sick. I've seen people with 13% lung function, okay? I've seen people who have had massive heart disease to the point that their ejection fraction is 20% instead of 65%, okay? I've seen people who are so sick in intensive care units whose muscles are so soft and floppy from inactivity that they can't even lift them from the bed. And I have seen these people come back over and over and over again over the course of 23 years, okay? There's a guy that I'm talking to right now, and I'm not going to mention his name because, I'm going to mention his name soon, once we have this finalized. But I have this guy who's got like very, very poor lung function, okay? He's got stage 4 COPD that is about to come to New York City and run the New York City Marathon, okay? And I'm going to tell you I'm going to tell you all about him very, very shortly, and I'm going to introduce him soon to you and let him tell him about yourself. But don't get discouraged by where you are right now. I can assure you that if any one of you, and I mean any one of you, okay, and this I could say without even knowing you, if any one of you were to walk into my rehab center today, I can promise you there is something we can do for you that is going to make you less short of breath, that's going to give you greater control over your breathing, that's going to make you more relaxed, that's going to let you do more activity, that's going to improve the efficiency of your lungs, that's going to make your heart stronger, and that's going to make your muscles stronger. So don't you dare sit there at home and say, you know what, I'm too far gone. You are not too far gone, okay? If you're listening to this webcast and you can hear my voice, we can move forward to this, and I will help you with it, okay? And it doesn't just mean with the webinars. If you ask me a question, I'm going to help you, okay? So stay focused on that. Let's go to questions from tonight. And this is my dude right here, Henry. Does air quality affect oxygen levels? And the answer is absolutely yes, okay? And related to my guy who's coming from Australia, okay, this is a big thing because where he lives, it's beautiful air. It's beautiful, nice and clean. He lives near the ocean, and he's coming to New York City where, guess what? It's not that clean, okay? Let's talk about how. The body is meant to protect you, okay? So when we talk about things like airway narrowing, when we talk about things like increased mucus production, okay, those are things that are meant to protect you that when you have lung disease have gone too far. They've gone into overdrive, okay? they have become hypersensitive. And so instead of just closing to protect you, they close to protect you, and they overclose. Instead of developing mucus to catch a toxin, okay, they are just producing mucus as if, you know, it's War of the Worlds, and it's overproducing mucus, which actually becomes an airway obstruction in itself, okay? So let's talk about, does air quality affect oxygen levels? Okay, again, I just mentioned that the body is designed to protect you. Again, I'm going to talk about New York City. It's where I live, okay, but you can equally apply this to a tractor in Kansas or a coal mine in wherever there are coal mines. Forgive my ignorance, but here's the thing. Have you ever been standing somewhere and a bus or a truck or something blows by you, or the wind kicks up and all of a sudden sand is around you, or wheat is around you, or dust or chemicals, okay, and it blows right in your face, okay, and you have no choice but to inhale it? Now, the body does not want to let that get deep into the lungs where it can become harmful to you and actually cause a disease or worse, okay? So what is the effect that's going to occur, okay? The first thing is, as soon as that threat is picked up, the body's gonna say, wait a second, we better bronchoconstrict. In other words, we better close the airways, right? So it's gonna close the airways to try to prevent, to create a mechanical barrier, okay, to that getting deep into your lungs. And the other thing it's going to do is it's going to call into effect what we call the mucociliary transport system. And it's going to start producing mucus. And in the airways, it's almost like an elevator that's designed to create mucus. And then there's the cilia, and the cilia are these very tiny hairs that start moving this mucus with the insult trapped in it out to the body where you can cough it up, okay, or sneeze it out, or this and that, okay? So that is how air quality affects oxygen levels. So when you know that there's a day where, let's say, either it's a very high pollen count or there's a very high ozone alert, okay, these are the days where you have to be particularly careful, because that's where your body is going to be particularly susceptible to an attack, and therefore particularly susceptible to the bronchoconstriction, the airway inflammation, and this increased mucus production. Now, if the insult is bad enough, okay, that can actually have some long-term effects, and it could actually create an exacerbation and or an infection. So if you're really in a jam, you have to communicate with your doctor, okay? And the thing is that, and again, this is beyond the scope of what we're going to talk about tonight, but there are ways to actually take your medicines to really protect you and get the most bronchodilation at the times that you need it most. So, short answer, does air quality affect your oxygen levels? The answer is yes. Barbara Barr, great, thank you, Barbara Barr, thank you. Okay, next question. We have misnomers in the ILD area as well. People focus on the idiopathic part of IPF being unknown cause. However, UIP, which is usual interstitial pneumonia, pattern of lung disease, tissue damage, while not unique to IPF, must also be present for the IPF diagnosis. Barbara, I'm going to challenge you on that, because I'm not sure. I'm going to say I'm not sure about that, but I'm going to say this. I'm going to say I'm not going to say I don't believe it, but I'm going to say I'm not sure that UIP must be present for IPF, because I think once you have a diagnosis of UIP, then we know it's not IPF. But I'm going to check on this, and now I'm going to talk about another webinar, okay, related to interstitial lung disease. But let me finish the question. There are people who have pulmonary fibrosis for which the cause is unknown, but they don't have the UIP pattern. Their diagnosis is not IPF, it's PF, and they just don't know the cause. Okay, I get the question now. I understand the question, and I do agree with you. Okay, you are correct, Barbara. There are misnomers, okay? And I'm going to direct you now to another webinar, and that webinar is under Web Archives, and that is called, well, there's two IPF webinars. So one of them is Special Event. That's a talk I gave at Cornell on the IPF Patient Education Day, okay? But particularly the one that I want to talk about is Webinar 18, which is Interstitial Lung Diseases with Dr. Robert Kaner. Dr. Robert Kaner is a super guru of interstitial lung disease, okay? He's from Cornell, New York Presbyterian Hospital, or New York Hospital, Cornell, I'm sorry. And he has been involved since ILD on the National Institute of Health level from way, way back. This guy has been involved in all the studies from the very beginning. And the webinar is Webinar 18, Interstitial Lung Disease with Robert Kaner. And here's the thing. We talk about the fact at the beginning, why is it so confusing? And it's confusing even to pulmonologists, okay? Let me tell you something. For that webinar, I had to study, okay? I don't study for these webinars a lot. Most of what I talk to you about is second nature to me, but I knew for ILD, I had to get my game up. And I studied, I researched, okay? And I had to be focused through that entire webinar. And even in one of the comments, somebody said, this seems bad because they're both so serious. And it's not that it's so bad, it's that we had to stay focused, and I had to stay focused to keep up with what he was saying because it's so complex. And I will say that Dr. Kaner made it really easy. I will say easier to understand, but I learned that night about interstitial lung disease in a way that I never understood it before. And one of the things that Dr. Kaner says is that it's confusing because it's not like asthma, emphysema, chronic bronchitis, where even if you don't know anything about the diseases, you think asthma and you kind of get the idea of somebody wheezing, right? Or you think emphysema and you kind of get the idea of somebody, you know, who's been a cigarette smoker for a long time and maybe is on oxygen. You have a general idea. But when we talk about interstitial lung diseases, we're talking about things like usual interstitial pneumonia, which Dr. Kaner says it's not usual, okay? And it's not necessarily pneumonia. We have things like pneumoconiosis. So if you hear something like pneumoconiosis, I mean, the closest thing I'm thinking about is an ice cream cone or something like that. But the diseases don't make any sense in a way, or they're not named anything that gives you any real insight into what they are. So you're right, Barbara, okay? Your question is correct, okay? But the thing is that IPF is a diagnosis that should not be made first. IPF is a diagnosis of exclusion, meaning that once all of these other diseases are ruled out and nothing is found positive, that's when the diagnosis of IPF, meaning idiopathic, meaning of unknown cause, comes up. But the thing that's really important to understand about this, and this is what Dr. Kaner said, and if you have any interest in ILD, interstitial lung disease, I strongly suggest you watch that webinar. But the thing that he said is most important is getting the correct diagnosis. And the reason why he said this is because some of the medications that are effective in the treatment of some ILDs are actually detrimental and harmful in the treatment of other ILDs. And again, because it's so confusing, not every doctor, not even every pulmonologist is going to be able to pick up on this. And that's why people with ILD are often misdiagnosed for years before it's picked up. So they may be diagnosed with COPD, they may be diagnosed with asthma and think that they have an obstructive disease for 3 years, 5 years, 7 years before somebody, you know, picks up on the fact that, hey, why does your chest x-ray look like this? Or, hey, why are your PFTs going down so fast? Or, hey, we better do a CAT scan to figure this out. So if there's any question of ILD, you need to make sure that you're with a team that really understands ILD. So I hope that, you know, so Barbara, we're in agreement on that, okay? But that webinar with Dr. Kaner is outstanding. Does getting older affect the progression of COPD from Rena? The answer is maybe yes, maybe no. So I'm giving you a definite maybe. There are people, I'm gonna say no, and I'm gonna explain why, okay? There are some people who, as they get older, the disease progresses faster. There are some people who, as they get older, the disease progresses slower. There are some people who, as they get older, the disease remains the same. So like Goldilocks, sometimes it's too hot, sometimes it's too cold, sometimes it's just right. But the thing is this, okay? Here's the thing about aging in the lungs. Lung function is at its peak at about 20 years old, I'm sorry to say. So other than Chris, everybody here has reached their peak lung function at 20 and is now on their way down. So we will lose anywhere from 0.5% to 2% of our lung function each year, even in the absence of lung disease, okay? So I'm gonna say it's not that your age is affecting the progression. I'm gonna say it's your age is affecting the fact that you're losing lung function, but not necessarily affecting the progression of COPD. All right, next question. Is pulmonary rehab possible on very high O2 needs? And this is Cynthia. I haven't found a way to keep a sat rate up, even doing what I used to be doing. Easy exercise at home. My concentrator goes to 10, and that's not enough to move at more than a crawl. Is it dangerous to exercise in my own gym if insurance won't pay? Okay, so the answer is it dangerous? If you're desaturating, it could definitely be dangerous. I'm going to assume that you're using your oxygen concentrator on 10, but with a nasal cannula, okay? A nasal cannula is a low flow oxygen delivery device, meaning that once you go above 6 liters per minute, the nasal cannula is no longer giving you any additional benefit, okay? So imagine this. Here's my cup. Here's 6 liters. My cup is completely full. So that means liter 7, liter 8, liter 9, liter 10 does not add anything to your oxygen saturation, okay? So what is the important thing here? At that point, ask your doctor if you can use a mask, particularly a non-rebreather mask, which are the mask that has the reservoir, and by doing that, you're actually increasing. So at 6 liters on a nasal cannula, or even 10 liters on a nasal cannula, because I just told you that 6 liters is the maximum, you're only getting 40% oxygen. And that's assuming we're actually using a tank full of oxygen gas, because a concentrator will actually give you a little less concentration. So if I give you 6 liters on a concentrator and 6 liters off a tank, you're always going to be higher saturated from a tank because it's pure oxygen. But that being said, even at 6 liters from a tank, the maximum you can get on a cannula is 40%. But if we actually give you the non-rebreather mask and bring it up to 10 to 15 liters, we're getting you closer to 70, 80% oxygen, and that should be able to keep you saturated. And we actually learned about this starting in 1995 is when I started seeing, for some reason, a lot of pulmonary fibrosis patients, IPF, pulmonary fibrosis, other interstitial lung diseases. And one of the things about interstitial lung disease is that the patients are often very scary to clinicians, and especially if they haven't seen a lot of them. And the reason for that is patients with ILD, they come in, they're super short of breath because their tidal volumes are small because they have restrictive lung disease, and their saturations go so low, okay? I've seen patients with interstitial lung disease whose oxygen saturation is 75%, which they've developed over time, okay? If I were sitting here and I have normal lungs, well, let's use Chris as an example. Chris has normal lungs. If all of a sudden Chris were at 75%, he'd be on the floor and I'd be administering CPR for him, okay? But for patients with interstitial lung disease, you develop a tolerance to that over time. But what used to happen, unfortunately, what still happens is that a lot of programs see you at 75% and they say, well, you know what? You're too sick for rehab. That makes no sense to me, okay? So at the time, my mentor, Horatio Pineda, MD, who is one of the giants of medicine and one of the key defining, figures in my career and my patient practice, we started talking about this, and we were like, what are we going to do with these patients? Because we get these poor, unfortunate people referred to us. They're so short of breath. Their oxygen saturation is terrible. They're scared. Even the clinicians who take care of them are scared. And we are turning them away from rehab because we're saying they're too sick for rehab. So that's like Alfred Hitchcock's movie Lifeboat. We're saying, sorry, you have to get out of the lifeboat. And we say, you know what? If they're too sick for rehab, and please don't take this the wrong way, but if they're too sick for rehab, what do we have to lose anyway by rehabbing them, right? If you're so sick that you're almost dead anyway, then we might as well take a chance on the unknown that no one's ever done before, which is rehabbing you. So what we started doing was we changed the way we deliver oxygen, because it used to be if you needed more than 6 liters on a cannula, well, you were considered, we would have no choice but to lower the workout in order to meet your oxygen saturation. So we would have to actually exercise you so gently in order for you to maintain an oxygen saturation of 90% on 6 liters, okay, that basically essentially what we had to do was lower it so much that it was barely beneficial. So instead we said, you know what? Let's give these people as much oxygen as humanly possible. Let's change the delivery system. Let's give them 100% oxygen. And all of a sudden, now these people who used to desaturate to 75% walking against the room were now staying at 85, 90%. Not perfect, but certainly much better. And what we found over time was that by rehabbing them in much the same way that we were rehabbing our COPD patients before, they started to increase their exercise saturations, increase their exercise tolerance, and then guess what? What happened over time was that they started increasing their resting saturation. And how did this happen? Because as I mentioned before, we improved the efficiency with which their lungs move air in and out. We improved the pumping power. We improved the pumping power of their hearts, and we improved the efficiency of their oxygen saturation. And now that's what we do with everybody. And again, there's another discussion which I won't talk about tonight because it's complex. But there's people who say, oh, you don't give a COPD patient too much oxygen because you're going to stop them from breathing. And again, when it comes to rehab and exercise, that is simply not the case. I've been giving COPD patients 100% O2 for the past 20 or more years, okay? And I've never had a patient stop breathing on the treadmill. And guess what? If they were by freak chance to stop breathing while they're walking on the treadmill, you know what I do? I go, hey, take a breath. And they would start breathing again, okay? So there's a lot of BS out there. There's a lot of people talking smack about how to rehab pulmonary patients. And pulmonary disease, trust me, it's becoming the hot disease, okay? Pulmonary disease is becoming the Nike of diseases. It's becoming hot. Love you, Nike, okay? We're gonna talk. But pulmonary disease is becoming what heart disease was 15 years ago. It's becoming cool because we're realizing that lifestyle can really help people with pulmonary disease. So now you're starting to see all these little bloggers, all these little articles being written. But if you look at the articles, okay, if you even Google exercise and pulmonary disease, yeah, 100 articles are going to come up on 100 different websites, and they're all going to have the same 7 bullet points. But guess what? Many of them are not correct. Many of them are based on misinformation. Many of these are written by staffers who have never taken care of a pulmonary patient before in their life. Trust me when I say this, okay? I'm not a doctor, but I've done more pulmonary rehab than the majority of people in the country. We've done more than 68,000 visits at the Pulmonary Center since we've opened. This is what I do day in, day out, nighttime, daytime, sleep time, nap time, meal time. I am always doing pulmonary rehab no matter what, okay? And that sounds crazy, but it's not crazy, it's what I do. So when I tell you something, you can put that in the bank. And if anybody wants to challenge that, you take any other pulmonary rehab center and let's have the Pulmonary Olympics, and my bet would be on Pulmonary Wellness and Rehabilitation Center. I'm not saying that because I'm cocky. I'm not saying that because my ego is big. Both those things are true. However, I'm saying it because experience speaks, okay? Next question. How do I know if my airway is inflamed, okay? A lot of ways, if you're having more difficulty breathing, it could be because of airway inflammation, but your doctor can listen to your lungs, you could do a chest x-ray, you could do a CAT scan, but you basically, if you're in doubt, if you're struggling and you're not sure, then by all means get it checked out. When in doubt, I'm always gonna say err on the side of caution and, and always, look, I'd much rather somebody who's in a jam go to the emergency room and let them say to you, you know what, we haven't found anything wrong, than stay home and really get into a jam. So if you're having any type of shortness of breath that can't recover, if you're more short of breath than usual doing your everyday activities, so in other words, if you get more short of breath doing the same activities, maybe something's wrong. Call your doctor. Don't wait 2 weeks. Don't wait 4 weeks, okay? You need to be seen when you need to be seen. Okay, so now here's a couple of questions from Barbara. And Barbara, I'm not gonna answer all these because it sounds like we might get into a fist fight, but I see something that says, yes, 2011 guidelines. I'm not sure what you mean by that, but I'm gonna look them up. UIP is not a diagnosis, is a pathological finding. If that's the case, then I am wrong and I will correct that, but I'm gonna look at Dr. Kaner's webinar, but I believe UIP is a diagnosis. If I'm wrong, I'm wrong. Sorry, UIP is not a clinical diagnosis again, and then you say exactly a disease of exclusion. Maybe I worked it out over the course that you were typing those questions, maybe not, but I will clarify that, okay, I promise, because it is important that we're all right And Barbara, I do know that you're extremely well educated about interstitial lung disease. So that answers all the questions. Ladies and gentlemen, thank you for tuning in. I want to just say, Breathe Easy Pulmonary Wellness for All. This is a great group, okay? I'm a member of many, many Facebook groups, and there are many, many good Facebook groups, okay? I'm totally biased, but this one I believe is one of, I know it's one of, I believe it's the best, which is why I spend my time here. So I encourage you to encourage your friends to join us. That being said, there are a lot, I just said it, there's a lot of good Facebook groups out there. So I encourage you to join as many groups as you want. I encourage you to be friends on Facebook or in real life with whoever you want, okay? I encourage you to get information from everywhere and anywhere that you can get it. And I will say this, there are a couple of groups that I want to tell you about that are sister groups of Breathe Easy. And when I say sister groups of Breathe Easy, okay, what I'm talking about, are groups that, have approached us that have similar goals in mind that I promote, okay, and because I think they're really good. But there's a lot of good groups out there, okay. One of them is Brenda's COPD exercises and recipes, healthy for everyone. And Brenda Rapp is somebody who really, Brenda, I say this to you all the time, Brenda Rapp is somebody who has Yoda-like knowledge of lung disease. And I don't know how she knows it all, and she has guru-type knowledge of exercise. So Brenda's COPD exercise and recipes, healthy for everyone. Another one is one of my friends, Buzza Shock, okay, and Buzza Shock has a group called Chronic Obstructive Pulmonary Disease. And again, anything I mentioned tonight, I'm going to link on the website. Okay, Buzza and I both have EMS backgrounds. The guy is super smart. He's a nice guy. He posts mostly art. So let me tell you first about Brenda's group. So Brenda is archiving all of our exercise info for us, okay? So Brenda's archiving all the workouts. She's putting up a ton of stuff, and she's putting up recipes. I don't have a kitchen in my apartment on purpose, so I can't utilize any of the recipes. But if anybody makes any baking or pastries or anything like that, please call my office for the address. I will always accept them. Buzza Shock's Chronic Obstructive Pulmonary Disease. Buzza comes up with some super articles, and Buzza and I are talking always about how we can raise awareness of COPD. I learn from his site every day because he puts up stuff. I don't have time to necessarily search every day, but he really scours the internet, and I've never seen him put up crap, okay? There are some sites that are just loaded with crap after crap after crap after crap, and you read the stuff and you leave stupider than when you came, okay? I'm sorry to say that, but Buzza is not one of those sites. Chronic Obstructive Pulmonary Disease is a great site, and this guy puts up great articles that I talk about, that I do. And then, today on the board, there was something that came up. There was a great there was a really good article about questions about cannabis oil. And, there's a lot of talk now about treatment with cannabis oil and pulmonary, pulmonary disease. And I'll be the first one to say I have zero experience with it, okay? I've never had a patient that, to my knowledge, was on it. But I'm interested in learning about it, okay? And there is a site, and I'm trying to find the name of it right this second. And it is called COPD Cannabis Treatment. Okay, so those are my 3 plugs for the night. Again, I'm a member of many, many groups. If you look at my personal page, you could see what groups I'm a member of. And I encourage you to join as many of them or as few of them as you feel comfortable with. Anybody who tells you, well, if you're in their group and then you can't be in my group, I question that person's motives, okay? I feel that we're all in this together. We should all be working together as a team, and that's how we do, and that's how I run my life, both COPD, IPF, lung disease, heart disease, scuba diving, photography, art, fashion, Nike, related, okay? So we want harmony in all things, and if you're joining a group and it's causing you more stress than it is pleasure and relief, then guess what? That ain't the right group for you, okay? We need to be putting all our energy into doing good things. So again, my people, I thank you so much for coming out tonight. Pulmonary Wellness and Rehabilitation thanks you. Breathe Easy Pulmonary Wellness for All thanks you. I'm glad you're all a part of my family. And like I said, if you have questions in between, feel free to reach out to me. And, you know, also feel free to reach out to the group, because I will tell you what I say over and over again. The overwhelming majority of what I know, I have learned from patients, okay? Everybody have a good night. Thank you so much. I wish you the best. Peace. That was a good webinar. That was a good webinar. We have a survey going out, right?